When I was younger, I'd never actually wanted to become a doctor. In fact, that wasn't even an option for me. I was dead set on becoming one thing and one thing only. And after hours and hours of intense research, I had decided to become a pink Power Ranger. That was my life goal. I spent my Saturday mornings watching hours of the Power Ranger TV show. That was my research that led me to choose this profession. However, the times have clearly changed, and I'd realized the sad, unattainable nature of this profession. So of course, I'd switched to other interests, and after going through several different career options like fashion design, makeup artistry, and architecture, I finally settled on anesthesiology. I decided that anesthesiology was the right profession for me because it combined my interests in sciences like biology and chemistry, along with my outgoing personality and desire to help people. However, I'm unsure of whether this is the right profession for me because a medical profession is a very high pressure environment where you have someone else's life in your hands. So I decided that taking ISM would be good to decide whether this would be a good fit for me. About me, I am deeply involved in student council and orchestra in school. There's a picture of me playing the harp, and I'm in art, so I love creating artwork, mainly abstract stuff. I'm not too great at realism. And I really enjoy traveling. My favorite trip I ever took was going to Europe, and there's me in front of Buckingham Palace. So this year I went on several interviews, 6 in total. The first one was with Dr. Cynthia Wowers, who works at Scottish Rite Hospital. The hospital setting at Scottish Rite is very unique. They don't have an ICU like an ER, so instead of having to come in with on-call hours, instead she goes in and has a set schedule that doesn't change as much as most other doctors. But she said that usually working in a hospital that's not as unique as Scottish Rite, it would be very hard to balance work and family. But when she worked in Georgia, she worked at this Embry hospital, and she had participated in the ICU there, and she said she got emotionally attached to a lot of the patients there because a lot of them would pass away after staying there for months and months. So that was another downside, she said, of anesthesiology, because you would get attached to your patients and sometimes they would die on you, so you would have to be careful to avoid that type of attachment. My second interview was with Dr. Tiffany Moon. She is an anesthesiologist and assistant professor at UT Southwestern. She specialized in trauma and vascular anesthesiology, so usually she saw most of the very sick patients or the ones who went through like gunshot wounds and stabs and all that type of stuff. And she said it actually made her feel kind of scared of the world because you could see like the worst parts of people getting hurt due to other people trying to hurt them. But she likes the feeling of helping people who would not usually be helped because Parkland is a public hospital and it provides medical care for all the people in need who don't usually get it, like illegal immigrants and people who can't afford to pay for hospital bills. But she said it was difficult for her to deal with an operation going wrong even when she knows that she did everything right, because she had had a life where when she tried to do something, usually it ended up going her way. But when she got into being a doctor, she realized that's not how the world really works. It changes. And even if you try everything humanly possible to help a person get better, they just might be too sick for you to help. So that was very difficult for her to transition into, but it gave me good insight on how a doctor has to function in their daily routine. My third interview was with Dr. Charles Witten, and he is the chair of the Department of Anesthesiology at UT Southwestern in acute pain management. Most of his work is administrative. He doesn't do as much clinical anymore because he's the chair, and so he has to oversee all the other doctors and what they work on. But he had majored in electrical engineering at SMU before going to med school as sort of a backup plan because he wasn't sure if he would actually get into medical school. But he said that it was a really good choice for him to major in engineering because he got a better understanding of how all of the tools in the operating room actually worked. He stressed interpersonal and leadership skills while working with other people in the OR because you have to interact with the surgeon, the RN, the nurses, and all those other things in the OR as well as your patient, and so you need to be able to communicate effectively with everyone that you work with. He said that this job was a very fast-paced and high-intensity job, And in order to be successful, you have to be able to adapt quickly and keep up with everything, because 1 minute you'll be in the OR and then you'll finish a case, but then you have one right after it and you have to switch gears and kind of see how, like you might be doing a heart surgery and then you have to go and do something with like, I don't know, an elbow being dislocated. So you have to completely switch gears on how you need to approach the operation. My fourth interview was with Dr. Jimmy LaFernie, and he is currently my mentor. He works at Baylor Medical Center at Frisco, which is super convenient because it's just like a 10-minute drive there. I don't have to miss too much school. And he was really good at giving advice. He told me a bunch of times to make sure that this is exactly what I want to do. Don't be in it for anything other than this is your passion. He approached it, anesthesiology, by explaining the corporate side, whereas other doctors mainly talked about what they did, and he emphasized how anesthesiology now is more of a corporate mindset and how you need to work with other people and develop better relationships with other people rather than just focusing on your patient, because hospitals now sign contracts with like a group of anesthesiologists and only work with those anesthesiologists from that group in order to provide anesthesiologists for their operations. He also mentioned how medicine had moved more towards patient satisfaction rather than just making sure that they survive. So after the operation, is the patient happy with their treatment? Do they feel pain, nausea after their treatment? You have to make sure that they feel comfortable with their operation rather than just did they live through it. My fifth interview was with Dr. Amy Gruber. She works for Anesthesia Resources for Children, which is a anesthesiologist group. She was the youngest person I interviewed, and she had finished medical school and residency about 2 years ago. So she gave me a lot more insight on college and medical school rather than the actual field of anesthesiology because she's so new to it. She really enjoyed working with kids because of their energy and the fact that they're not responsible for what happens to them. Instead, a lot of the things that they're in the OR for is because genetic things, or maybe they fell and hurt themselves, but that's not really their fault because they're just being kids. She said that when you're in the OR, you're kind of learning in front of a crowd, so you need to keep a good poker face in case something goes wrong. You don't want to scare your patient or like the parents of the kids in the OR, so you need to keep a good poker face because it's kind of like acting while you're a doctor. She emphasized picking an interesting college major because you're going to be studying medicine for 4 years of med school and then the 2 years of residency, and if you plan on doing a fellowship, then an extra year of medicine after that. So that's a total of 7 years of medicine beyond the 4 years of college. So why major in like biology or chemistry like everyone else does? Instead, pick something else that you're interested in. So I like that advice because I have other interests like engineering. So along with what Dr. Witten said, I figured that majoring in engineering could help me as a doctor as well. My sixth interview and final interview was with Dr. Lindsay Grover. She's an anesthesiologist at Children's Medical Center in Plano, and she loves working with kids. Even though they never really think to say thank you to you after they go through an operation, they don't realize what you've done for them. She enjoys the energy and like the unspoken gratitude that they have. She really, really stressed people skills. The whole conversation was mainly talking about people skills and how you can be an absolutely awful doctor, but if you know how to talk to people properly, they'll still like you. She said that there was this one doctor who worked at a hospital that she used to work at, and he was absolutely awful as an anesthesiologist, like 100%, didn't know what he was doing most of the time, but he was so good at talking to the patients that almost everyone requested for him to be their anesthesiologist because he was so good at like talking to them, making them feel comfortable. And I thought that was really interesting and strange that a doctor that doesn't really know what they're doing is actually so well liked by people, but it kind of showed me how important having people skills is. And she really, really tried to make me see that I have to do what makes me a happy person and making sure that this profession is right for me, because a lot of the doctors she worked with are generally happy with what they do, but several of them feel like that they don't really like medicine and they only stuck with it because they had gone through so much medical school. And so she emphasized that I have to really make sure before going into medical school if this is the right thing for me. And she also talked about number sense, which is like making sure you can do mental math well inside your head. I do Math UIL at school, and number sense is actually the title of one of the tests that you take, where you have 80 minutes, or not 80 minutes, 10 minutes to do 80 questions, no scratch work, ink, and it's crazy. It's really difficult. I've gotten a negative score multiple times, but she actually talked about how she did Math UIL in high school and how it really helped her as a doctor, so it makes me feel like I'm on the right track. And other than interviews, I also conducted research. Overall, I mainly researched articles and studies relating to pediatric anesthesiology because that's what I originally wanted to do. I intended to shadow a mentor who focused on pediatric anesthesiology, but my mentor actually just does general anesthesiology. But I found out that it's a good fit for just to get a general idea of anesthesiology. Most of the articles gave me insight on the behavioral effects and long-term health effects of using drugs to sedate a patient. So a lot of them analyzed how drugs could potentially have negative effects depending on how long the patient was sedated, the strength of the medicine used, and other factors like that. Two of my notable assessments I will talk about. The first one is one about like maternal anesthesia and used when a fetus is in the mother's womb. And it was a very important, interesting discussion about weighing the importance of a mother's safety versus the fetus, because sometimes a medicine might need to be used that could harm the mother but could potentially save the fetus. So they're weighing whose life is more important in this situation, and I thought that was really cool to see which life would be more important when using medicine. The article didn't really pick a side; it just weighed the different factors that could affect both the mother and the fetus. But it also brought into light the long-term health defects that could possibly be related to the use of sedatives in the womb. It talked about how babies after they were born could potentially have birth defects because of the use of medicine while they were in the womb, that the mother had a procedure on maybe before they were born, or if the mother had a different surgery in a different part of the body but she needed to be under anesthesia, and how it can potentially lead to birth defects. So I thought that was very interesting. And then my fifth research assessment was over the UNT trip that we took. And I went to 3 classes. One was Biology 2 for science majors, Health Psychology, and then Biomedical Engineering. In the Biology 2 for science majors, they talked a lot about the menstrual cycle, which was actually interesting. I learned a lot more about the menstrual cycle than I thought I would learn ever. And then Health Psychology talked in depth about diabetes and the effects it can actually have on the people that have diabetes, which I thought was very interesting because I have several friends who have diabetes, so it helped me understand what they were going through a little bit more. But I liked the engineering class the best, and they talked about how to make a thermometer, like engineer one with all the circuits and stuff, and most of it was over my head, but I kind of got a grasp on it, so I really felt like that was a good fit for me. And it also gave me ideas for my original work that I could try tying in engineering into my original work because I really enjoyed the engineering class. So my original work, the objective was to research the common problems that can occur when using endotracheal tubes during anesthesiology and design an endotracheal tube or related component that can help fix the complications that occur during a procedure. I got the idea to use endotracheal tubes because I had worked with my dad last summer on a project he did with the UT Southwestern Department of Anesthesiology. They had requested for him to make a machine that can pull out an endotracheal tube from a patient if there's an emergency, in order to figure out what the best method of taping the tube down around the mouth would be. Because during a procedure, after they put the endotracheal tube in, they tape the tube down in order to keep it in place. But if there's something going on where the tube needs to be taken out, they need to be able to do it quickly without hurting the patient. So they needed to find a taping method that was both secure but also flexible enough to be taken out. So that was kind of led me into the whole endotracheal tube thing. So I decided that there probably was other complications that they had with using endotracheal tubes that I could research. So this is a picture of an endotracheal tube, and what it does is it goes into the throat and it rests right where the bronchi start to split after the trachea, and then they inflate that little bubble there to help keep it in place. And after doing some research, I realized that a lot of people actually, when they're sedated, they have a reflex where they bite down when they are under stress. So when the surgeon starts cutting into them, they might bite down automatically as a reflex action. So sometimes that will kink the tube and prevent the airflow from flowing through it properly. So I decided to design a mouth guard that would go right around the tube and rest so when the patient bites down, it will diffuse the tension from being pushed onto the tube and instead just go around onto the teeth. So I took the idea of a boil and bite mouth guard where they boil the plastic before putting in the patient to get a good fit for the mouth guard, and then line the outside of it with silicone, which is a common material that you can see on kitchen utensils, in order to keep it flexible so the patient doesn't hurt themselves when they bite. So these were all my designs. I have 5 diagrams. There you can see there was the thermoplastic mouth guard, the boil and bite, that goes on top, and then the silicone piece that gets placed around it where there's a little arched gap so that the endotracheal tube can fit through it. So basically the anesthesiologist will put the endotracheal tube in first and then place the mouth guard with the silicone pieces afterwards, so that the mouth guard can fit around the endotracheal tube. And so when the patient bites down, you can see that it just won't harm the endotracheal tube. It just goes around it and it just pushes down on the sides. So there's some other views. Here's a front view, just so you can get a better idea. And I took each component apart. Here's the top is the upper thermoplastic mouth guard, and then the silicone that goes over the mouth guard, and then you can see that there's the arched gap where the endotracheal tube will fit, and then there's the bottom components as well. And then here you can see where it would be in the patient, so that they put the mouth guards there and the endotracheal tube goes down into the trachea. And then the front view where the mouth guard is in the mouth. And then I have my mentor, Dr. Jimmy LaFernie, and he's, like I said earlier, the anesthesiologist at Baylor Medical Center. I had 2 mentor visits with him so far. He's a little bit difficult to schedule with because he's also the VP of Medical Affairs, so he has a lot of other paperwork to be doing as well. But we finally figured out a good schedule of how to schedule things and meet up, so it's good now. My first visit, I saw 2 operations in the OR. This was on the first Tuesday of winter break. I saw a total vaginal hysterectomy with a transvaginal sling implanted. So the lady had her uterus removed, and then they put a sling so that the stomach and other components wouldn't slide down to the space where the uterus was supposed to be. And as my first mentor visit, I had never been in the OR before, and it was a completely new experience, and I didn't realize that you needed to eat a lot before you went. So I almost passed out. I had to lay down on the floor in the OR while the lady was being cut open, and they brought me apple juice and crackers so I wouldn't, because I was sweating, I was laying on the ground, and I was spinning and everything, and I couldn't see anything. So they were like, I don't think she ate enough, let's go get her some food. So I'm just sitting there in the corner eating while the lady's having surgery done, and I felt kind of bad, but it was a good lesson. I learned to eat more before I go on mentor visits. And then the other operation, which I handled much better because I'd gotten something to eat, was a laparoscopic lysis of adhesions from endometriosis. And endometriosis is basically where the cells that are supposed to grow in the uterus and the ones that bleed during a girl's period end up growing in other places of the body. And so those can be really painful for the woman that this operation was on. It happened to be in her small intestine, so they had to cut open her small intestine, and then they cut all those adhesions off or burn them off, depending on how big they were, and to kill the cells and keep them from bleeding every menstrual cycle. And then my second visit, I didn't go into the OR, but we did a lot of planning for the year, and we talked about my goals of what I wanted to learn. And I told him that I really just wanted to see what an anesthesiologist does in the OR, and he said that that was a good goal and that he would try to get me to see other types of doctors and how they handle the OR differently, because every single anesthesiologist is different. And he also said that he wanted me to see a life and death situation in the OR, and he said it sounded really bad, but it would give me insight on like what a really serious situation would be like. And then we talked about the start of my final product, which he was talking about how when anesthesiologists are in the OR, they have to record every 5 minutes what is going on with the patient, like the oxygen levels, heartbeat, all that type of stuff. But they don't have like software that can automatically record it every 5 minutes. Well, there is, but he said it's very cumbersome. So he said that that kind of gave me the idea to do something maybe about designing a new software or trying to do research into how to make a more effective software. So I told him this at my last mentor visit, and he said that he could actually get all of the people who are part of the companies that make these softwares, and he can have them come down and we can talk to them about what would be a good software to have for Baylor Medical Center. So I'm really excited to start doing something like that. So throughout this year so far, I've learned a lot about myself that I didn't quite know before taking this class. I had been convinced that medicine was the only path for me, and ever since 8th grade I was convinced about that, but now I'm not entirely sure if that's exactly what I want to do because of my conflicting interest with engineering and design. But with the help of my mentor and all the research I've done so far, I realized I can tie those two interests together, maybe through the software that I'll work on, or like the endotracheal tube design I did, or any other things with biomedical technology. I'm going to try and integrate these two technologies this year to make them truly fit together and be a personalized fit for what I'm passionate about this year in ISM. I hope to continue to learn more and more about myself, and that I will spend time shadowing Dr. Lafferty in the OR to expand my knowledge in the field of anesthesiology. I hope to gain more knowledge on how this profession plays a role in the world of medicine. And even though this path is one full of uncertainties, it is definitely a step in the right direction to determine what path is right for me. This is why I feel such a personal connection to this quote by Christopher Columbus that says, "You can never cross the ocean unless you have the courage to lose sight of the shore." I feel like this quote reflects exactly how ISM pushes me and everyone else in this room to lose sight of what is comfortable and familiar in order to allow us to learn new things in the professions that we want to have. Thank you for listening to my speech.